So the next two speakers, first let me introduce them. We're proud to have here with us today Ellen Cadigan Mazel. Ellen works for the Concord Area Special Education Collaborative, also known as CASE Collaborative in Concord, Mass. She's also a teacher of students with visual impairments, deafblindness, and cortical visual impairment. She works with the Minuteman Early Intervention Program in Concord, supporting infants and toddlers with visual impairments and their families. She teaches cortical visual impairment, assessment, and education in the Vision Studies graduate program at the University of Massachusetts in Boston. She's worked 10 plus years in educational partnerships at Perkins School for the Blind. And in fact, in 2008, while at Perkins, Ellen was named National Teacher of the Year for Children with Multiple Disabilities by the Council of Schools for the Blind. So congratulations on that. She's also an active blogger, and she likes blogging not because she's tech savvy, but because she hopes blogging will generate more referral for children so that they can improve their visual skills. Second co-presenter will be Tracy Evans Luiselli. Tracy is the project director for New England Consortium for Deafblind Technical Assistance and Training. Try saying that 3 times. She received her M.Ed, Master of Education in Deafblind Education at Boston College, and her doctorate in Early Childhood Special Education from the University of Massachusetts at Amherst, which is a great university, my alum. Tracy has experience teaching children who are deafblind in a variety of settings, example, public schools and home-based settings. She served as an adjunct faculty at Boston College as well as Simmons College, and she has presented and written extensively and is certified in low vision, moderate special needs, intensive special needs, and elementary education. Please join me in welcoming our two co-presenters for the next presentation.
Good morning, everybody. I'm a little intimidated by the quality of the information in this room right now. How many people, for whom is this their first meeting about CVI? Wow, quite a few. I like to say that learning about CVI is a little bit like learning about sex. You've got to keep coming back and listening to it. It's like, oh my gosh, there's no stork. Like, it blows your mind. So I'm glad you're here. But as we heard already this morning, please don't let this be your last conversation about CVI. So today's goals that I was asked to, speak about was a little bit about CVI from a teacher's point of view, discuss the evaluation of CVI, and to discuss some theories, specifically Dr. Roman and Dr. Dutton. So CVI assessment is also used with older kids, so we'll be talking a little bit about that, and some of the considerations for increased age. What about older kids and CVI, and improvements and expectations. As we've heard before, CVI is all in the brain. It's damage to the visual cortex, to the visual pathways, or both. Some of this is going to be a repeat, so I'll try to get through it quicker because you don't need to hear it again. They just don't understand the visual information, and again, it's very, very important, important to know that this is the primary visual impairment that we're seeing. I have 26 children on my caseload, 25 have CVI. So, that's, I work in a collaborative, so I tend to have kids with multiple disabilities, but that's a huge number. So what I want you to do when I think about throwing out the stork is rethink this whole issue. As Derek said, when we all went to school, we learned about the eyeball. We learned about the eyeball, we ended at the optic nerve, and we thought about nothing else. And I'm embarrassed to say that now, really, thinking about, this is my 37th year of teaching, that we did not think about the brain. We did not think about how that all worked. And when I first started to learn about CVI, I thought to myself, this whole brain thing is huge. It's not just how the brain is processing the visual information, but how is the child's brain processing hearing, or taste, or touch, or smell, all those compensatory skills. And again, I'm embarrassed to say I hadn't given that much thought. I thought about compensatory skills in a very, very limited way. So this whole adventure for me has really opened up my understanding and really launched me into thinking more about the brain. And in the resources today, I just have some sort of lay people resources that you can go in and educate yourself about the brain. Because this is the decade of the brain, we've got to keep up with the information. It's changing rapidly. Here's just a picture of the brain looking down, sort of from above. And if you were to look at this picture, it's the eyes and the brain, the visual pathways. Where do the eyes end and the brain begins? In a sense, I feel like the eyes are the gathering point. They're the piece of the brain that gathers the information from the outside. So again, I think we've moved into thinking more about the holistic brain, not just about the eyes as a separate entity. Derek already talked about this. This is the dorsal stream and ventral stream. The dorsal stream is where is it? The ventral stream is what is it? So where's the target? The dorsal stream tells us where it's oriented in space. It's responsible for eye-hand coordination and also some eye-foot. If you don't know where you are in space, you can't really function that well. And it gives us the perception of movement. Again, the ventral stream, what's the target? So it's going to recognize faces, facial expressions, colors, shapes, writing, any kind of objects. That's all going to be in the ventral stream. So when you start thinking about the different theories of CVI, they sounded, I think in the beginning, to be, there was a lot of conflict in what people were talking about when they were talking about CVI. And APH, the American Printing House, had an advisory group in 2008, and they got together to kind of come up with some common thoughts around CVI. Christine Roman, Lansky, and Dr. Dutton were part of that group, as well as 9 others. So here's what they did have agreement on. That it was a brain-based visual impairment of the visual cortex and visual pathways. That all children with CVI should be considered visually impaired. I think that's a very, very important thing to remember. That all children, regardless of the severity of CVI or the severity of multiple disabilities, deserve vision services. So that, again, is another very, very important piece. I think when we first had kids we called cortically blind, we blamed them and said they're so cognitively involved that they just can't use their vision. And I think that was a disservice. That was a way of thinking about it that didn't really give them the benefit of thoughts about their vision. And again, I'm embarrassed about that. The criteria for CVI, they agreed, was an eye exam, but that eye exam did not support the level of functional vision that they saw in these children. Typically what they saw was a history of neurological problems, something else going on in the brain. Sometimes the doctors can't find a brain abnormality, and the child still functions with some CVI. And again, I think we just don't know that much about the brain in order to be absolutely sure we've got it all. There's fMRIs that can show parts of the brain that light up, but they don't really understand how the information travels yet. That's something that they're really working on. That's called diffuse spectral imaging, I believe. And there were distinct behavioral characteristics of kids with CVI. So what I think they decided was that you can't take a child to an eye doctor and get a diagnosis of CVI based on any medical tests, really. You can do a test for brain damage, you can do an acuity, but you have to really look at those characteristics in order to give a really good criteria for CVI. And I think when I think about that, I think about autism. You can't take a child to the doctor and medically in their brain see autism, but yet their behavioral characteristics line up. And I think that it's very similar with CVI, that we have to think about the behavioral characteristics when we think about diagnosing kids. For low vision and legal blindness, CVI is defined that the visual acuity, those traditional visual acuity measures just don't work for CVI. We heard that a little bit this morning. It's not enough information. I would always recommend that kids go to a low vision evaluation. I'm plugging you guys because you get an excellent low vision exam. But that's going to give you a piece of the number. It really has to be a collaboration. One of the things I really like about the low vision clinic here is that there's real focus on gathering information from the people that know that child best, because that sort of sterile room that you're in is very different from that busy classroom. So that's a very, very important piece. Visual fields are affected, as they know, and their visual abilities are just not like their peers. There was agreement that the functioning of CVI goes from severe to mild. There was agreement that you always have to screen for ocular impairments. And I think in my work, the most common ocular impairment is strabismus. That seems to be the inability to keep your eyes in the same place. You'll see kids with CVI, some levels of CVI, just use one eye at a time. And the functional vision assessment, the old functional vision assessments that we all did on kids are not that valuable for us at CVI. We have to put the assessment of CVI, the functional vision assessment of CVI, in a totally different category around these 10 characteristics. And here were the characteristics they identified: light gazing, poor visual attention, color preferences, restricted fields, difficulty with visual complexity, difficulties with distance viewing, and I think about distance viewing as complexity. If I hold my pen close to my face, it's larger, it feels more of my visual field. If I put it across the room, I've got to look at all of you, plus try to find my pen. So I see that distance inability as a function of complexity. There's a better visual skill with known objects. So the kids that have seen things before. I had a little boy who had a Kelly green bear in his crib from the time he was born, and that Kelly green was the color he preferred, and he could locate that in many different places against many different complex backgrounds, because that was a very, very known thing for him. Attention to moving objects was another feature. Looking away while reaching. Visual latency, that visual length of time that it takes to find something, or the length of the time it takes to understand something. An atypical blink reflex, that's touching the child between the eyes. You get an immediate blink to the touch between your eyes, or a flash or a threat to the face, you get an immediate blink to that threat. And to recognize that looking at something doesn't necessarily mean understanding it. So that was an important concept I think came out of that 2008. All children, this was also a statement that came out of this meeting, all children, nearly all children improve, but rarely does anyone resolve. So basically, on Christine Roman's scale, nobody's a 10. Nobody gets to 10. That's an important concept, because I see sometimes reports coming from people saying that kids have resolved, and then I see problems with distance, I see facial recognition problems, so kids are never getting to the 10. So where's the disagreement? Yes, go ahead.
When you say they never resolve, you mean with or without services?
They never, even with services, those things hang on. Those characteristics are the most difficult. The complexity is, facial recognition is complexity, distance is complexity. Sometimes fields hang on. There's differences in how they use their certain visual fields. So just certain things will hang on. Yes.
So would you say that that you see as a result of services, you see abatement or significant reduction in some characteristics, and depending
Absolutely.
upon the environment and the novelty, they may resurface?
I see improvement in all the children I've worked with, and I have had the benefit of working with many of the children, some of them from babies, from 8 or 9 months old when I picked them up in early intervention, and I followed them through. Some of them are, 14 and 15 now, and I have seen improvements. Improvements are related to cognitive ability, certainly, but every child has improved unless they have a degenerative brain issue. That's one place that I would not see it. But even within complexity, I see improvements, but things still hang on. So I tend to think of cafeteria and they're looking right here. They're not looking around at what's going on. They're close lookers. Or you walk into a classroom and this was in a 7th grade and I was asked to evaluate this boy and I noticed every time anybody came in, he was the class clown. So he'd say, oh, here comes trouble. And then the teacher who walked in would say, Billy, that's inappropriate. And Billy would say, oh, that's Mr. So-and-so. That was his strategy to figure out who was coming in. He was masterful about it, causing trouble to get you to talk to him. So really, really clever, really, really clever. So our disagreement, yes. Yes, I'm sorry.
It's the atypical blink reflex. I know that's at a much lower level. Is that always required?
Always required as
Well,
far as assessment?
The APH, the group that agreed on this list
Uh-huh.
of things. Are you always going to see an atypical in their view?
I think that one is the one that resolves. I think that as you look at a Christine Roman scale, for instance, I see that as one of the ones that would resolve,
So
as I would like gazing.
It doesn't have to be present.
It does not have to be present, but it would be one of the things we would look at.
What does it look like, atypical?
Atypical means that if you touch them between the eyes, you see either no blink or you see a slight blink. If I touch a person with typical vision between the eyes, first of all, they're not going to let you get that close to their eyes. But they pull back, they blink immediately. Same thing to threat. It's a reflex. It's your visual processing. It's how that's the speed with which you're going to react to something like that. Yes.
Yeah. Are you able to get older children to be able to articulate to themselves how to work around and compensate?
I think children come up with really interesting compensations on themselves, as I just mentioned, my friend Billy. We want to have Billy come up with some other strategies besides that. So one of the things that I would put on Billy's IEP is that maybe there's some discussion at the beginning of the day about what somebody's wearing. You know, hi Billy, I've got my check shirt on today. So later on, when Billy sees a check shirt at distance, that salient feature can be in his mind. He can hang on to that cognitively, and that becomes his way of knowing who's coming and going. There was one of the case study talked about anxiety. Imagine not knowing what was going on all the time. You know, I mean, I think I would be anxious if I had CVI. I would be very anxious. So yes, I think that there are very definite strategies that we would put in place to do this, except for reflexes. Obviously, you're not going to address reflexes with any kind of accommodations. But I think it's important to keep checking. So this disagreement, as we've already heard about the term, but isn't it lucky that each one of those letters says CVI? So we're all set. We don't have to call it anything in my business, just CVI. So Dr. Roman does CVA, and she's interested in the functional, evaluation of functional vision. She again, with everyone else, was talking about definitions and causes. And then she developed an assessment tool, and it was the Christine Roman Lansky CVI range. And in the handout today, the handouts are over on the table on the side. There is the title of her book is there, and you can take a look at the study that was done in the Journal for Visual Impairment and Blindness that talked about the reliability. At this point, this is the only tool we have to assess functional vision. It had inter-rater reliability and overtime reliability. So you can read that study, and as I said, the link is there. So she published this book, which is Christine Roman's Lansky's Cortical Visual Impairment, an Approach to Assessment and Intervention. So she's looking at strategies and environmental supports. She again is discussing the dorsal and ventral streams and how it seems to be that kids with CVI in the very early stages can't even figure out where something is in space. They don't even have, like their dorsal stream isn't really even functioning. And then they seem to, over time, gather that ability to see those finer things, those faces. They can look. Now they're looking, but it's that recognition piece that's hard. So here are her 10 characteristics, and I have a handout that talks about, just lists these characteristics for you, and also talks about the phases and some of the phases and how they work into her interventions. So color, movement, latency, you're hearing these a lot today, visual fields, complexity. When I think about complexity, I think of three things. I think of visual complexity, auditory complexity, and positional complexity. And positional complexity is especially important with our kids with motor issues. If they're not solidly seated, they're not using their vision as well as they could. Light gazing, distance viewing, visual reflective responses, which is that link to threat, visual novelty, and visual motor, and we've already heard about that reaching without looking. So when we look at the 10 characteristics, and we assess them, Christine Roman's scale assesses those 10 characteristics. And with color, we want to know which colors do these kids attend to. Do they attend to any color in particular? And kids tend to do the very, very bold colors. They do the saturated colors, most often the reds and the yellows. And there was an interesting study. They had two twins go into a party. One was dressed in a red dress and one was dressed in a multicolored dress. And these are identical twins. And they charted how often someone talked to the woman in the red dress. And it turned out they talked to her 3 times as much as her identical twin sister. If you drive a red car, you will be pulled over by the police much more often. And so that red is a very salient feature, that fire engines are red, stop signs are red. It's just a very, very, I have heard, and I don't know this I haven't read it for absolute fact, but that there's more brain power used for red. There's more neurons devoted to the color. I don't know that for sure. That's worth looking into. And again, I really encourage you to read anything you can, get your hands on anything you can that talks about the brain, because this is what CVI is. If you can understand more about the brain, you can really put CVI in context. So we have movement. Does the child attend to moving materials? I have kids who will not look at anything unless it has movement. Then they progress to a certain point where any movement distracts them from what I want them to look at. So it's like the good news, bad news, but as they move along, movement is a very important feature of their looking. Latency, I want to know how long does it take this child to find something? Because educationally, I've got to make sure that material stays that length of time that child needs. Visual fields. Do they see better in one visual field than another? And again, educationally, I need to know that because I need those materials in the best visual field. Again, complexity, visual complexity. I'm going to want to know how much can they look at one time without getting overloaded. I'm going to want to know how much noise can they tolerate. If the noise becomes familiar, are they okay? But then I bring them into the auditorium and they just totally stop using their vision. Or unexpected noise makes them stop looking. Positional complexity, again, really in their IEPs, really saying these children need to have solid positionings when they're doing visual tasks, which should be most of the time. So this is a picture that I have here of a typical classroom. It's 3 bookcases that are 4 shelves high, and each is filled with colorful preschool toys. That's what you're going to find in most preschool classrooms. So this is an adaptation that I suggested, and what we did was we just took tension rods, curtain tension rods, we put some black fabric, and just covered all that mess so that the child's visual background was completely simplified in order to make that environment a better learning space for these children. The next characteristic is light gazing and non-purposeful gaze. Looking at light is just not that functional. So we really want to be bringing them back from light. What's interesting is the kids that light gaze, if I use light boxes, I use backlighted materials, I get better responses, but there's meaningful things in front of those lighted materials. So it's much more important than looking up over your head. Distance, what distance does the child see best? And again, that's something very important for me to be assessing in a classroom to figure out where a child can see best. Visual reflexive responses, I always check this, although of course because it's a reflex, I am not programming for that. Visual novelty, does the child like familiar things and seem to ignore other things? Parents will say, gee, I brought, Christmas came and I gave them the new toy and they just don't care about anything that I bring them that's new. Just leave it in the environment. The child just needs time to have it around to see. Educationally, what am I going to recommend for kids that are struggling with visual novelty a math class, don't keep switching the manipulatives. Use one kind of manipulative so you're not making the child see a new item and learn a new math skill. Standardize your things. So that's a very important concept for me to know. Visual motor. Does the child reach to things at all? Do they reach while they're looking? And do they play while they're looking? Think about a typical child who sits and plays with material. They're looking at it because what they're doing with their hands is causing something to happen. So we want to know if kids are looking while they're playing. CVI, Christine Roman has put CVI on a 10-point line. And remember that each one of the characteristics that we've talked about appears on that line. So a child that's operating at a 0 has very, very minimal vision use at all. And someone at a 10 has typical vision just like their peers. And as we said, nobody's getting to a 10. There's always something left over. But when the child improves, what we tend to see is improvement across all 10 characteristics. If you line the 10 characteristics up, that you tend to get movement in improvement along all 10 of those characteristics. You don't get a scattered pattern that you might see with other skills. You tend to see things move along. So this is just and this also is in your handouts, a link to this. This is Christine Roman's, this is the front page. So she's doing, in her assessment, she's looking at kids in two ways. It's the CVI range, and she looks at rating 1 and rating 2. In rating 1, she's thinking about across characteristics. How is a child within a certain category of CVI functioning across all characteristics? So let's just go to the next slide and I'll show you. So for instance, in 1 to 2, the student's functioning with very minimal responses. They locate, but there's no fixation. They may locate, but there's no fixation on objects. They're consistently attentive to lights. There you got your light gazing. They have prolonged periods of latency. They respond only in strictly controlled environments. I've got to have black backgrounds. I've got to have it completely quiet. I have to completely design I couldn't wear this shirt, for instance. This would be too much as a background. They attend in near space only. So that you see within this 1 to 2 category on the range, she's talking about all the characteristics for that child, that early child. The second rating is looking at the skills within the particular characteristic. So I want to know, within the characteristic of color, do they have any skills at all? Do they look at just one color, or do they look at all colors? So again, you're going to start with a 0 if they only look at one color, and if you have a resolved, that means that they look at all colors just like their peers. They don't need any supports at all. They look just like their peers. So very much you see that very few kids are going to get 1s on this part of the scale. So she looks at the phases, she looks at the severity, and she places children into phases. And again, you're hearing a lot of new vocabulary. Remember what I said about sex before? There's a lot of new vocabulary, and you have to keep coming back. So I've talked about range, rating, phase, all these characteristics, all these words, they're brand new, and you just have to keep hearing them. You just have to keep reading about them. And this is purely an overview. And in the handout that I have given you, there are several resources that are online resources that you can really delve into the topic. There's Dutton does a nice webinar. There's lots of teaching resources at Perkins. There's, I did the class at online for CVI at UMass. There's a couple, I think it's American Federation does, I think Christine Roman has a series of webinars. So delve deep, don't let today be your last encounter. So phase 1 is kids are scoring between 0 and 3. These are very, very, very visually impaired children. In phase 2, they're about a 3 to a 7, they're in that mid-range, and improving, we're seeing improvements. And phase 3, they're 6 nobody's getting to attend. The reason that that she put these categories into phases was that you have a very, very different goal for each phase. So if a child is in the early phases, if they have very minimal vision, you're really going to be, they are a very, very visually impaired child. But we want to have them build those visual skills, build those visual pathways, build that recognition. So our goal is just looking. That's all we want. We want looking, 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 looking. So we want to set the environment up in near space so that there's always something for these children to look at. By the changing table, in the car, everywhere they are. We want something salient of their favorite color for them to look and interact with. When you move into phase 2, kids' vision is improving, but we want to have that vision and function. Vision and function is putting things somewhere, picking things up. It's that visual motor piece, and this is a great place to be working very closely with any occupational therapist because we're all in that same visual motor business. In phase 3, you're resolving some of those characteristics. And as I said, some of the characteristics left over in phase 3 are facial recognition, sometimes lower field. You're going to have they're going to be close lookers. They're going to have social problems if they have problems with facial recognition. They're not going to understand facial expressions. Yes?
Do you have data on how long, or the amount of time that might be involved in achieving some of those goals, or how much therapy, or the frequency of therapy?
Oh, what a great question. I don't. I think it's, as you heard Derek this morning, every kid is so very different that the important piece is that we assess each individual child very, very separately, because each individual child has a CVI score, but they also have a certain level of motor impairment, perhaps, or a certain level of hearing impairment, or a cognitive issue. So each child has to be considered so differently. I think Christine Roman is doing some research about how many years or what's the expected time. I think it's a tough question because you don't have 60 kids that are all the same that you can do this kind of research on. They're all so very different. Even if I have children all in phase 1, they're so different from one another. And that's why I think assessment is so important. That we just don't say, oh, this child he's really bad, like maybe they'll say that, really bad in CVI, so we'll just do this for them. That may not be what they need. That's why specific assessment around those 10 characteristics is so important. But I wish I had an answer for you. As far as delivery of service, I am very, very passionate about the fact that these kids deserve service, that just because they have CVI or they have multiple disabilities does not mean we can't work on their vision. And I think this is the whole expectation of improvement, I think, is the cornerstone of CVI. I think when we had kids with ocular impairments, we're looking at the ocular impairment and we're working around it all the time and making adaptations to it. Whereas with CVI, we want to acknowledge what those characteristics are and really directly make strategies, and importantly, pull the strategies away when that child's vision improves. Yes?
When you have a student with CVI, how often would they redo the Roman scale testing? And also, when you have a student with CVI, for us who work in the adult services or children's workers, we should be asking for that assessment, be sure it was done?
Yes, I would think you would want to know, it should be in any transition report at all, because it is functional vision.
Okay.
So your TVI, it should be rolled into functional vision. And I do a functional vision assessment because I seem to always have kids with strabismus also. But then I do the CVI, and to me it's all functional vision. So yes, you should be getting that. And because it's the only tool available to us right now, this is what we should be using. Yes. Oh, sorry. Go ahead.
Okay. I'm wondering, as the vision is improving, if you see a cognitive change too.
She said, when you see a CVI change, you see a cognitive change. You know, I think you see, you see improved access to information, if that answers the question. You know, what's the number, 75 to 80% of what you learn is through your vision. And then you impact that with a child who can't necessarily get up and go move to find something. You know, I think it's access to information. That's very important. We have one more question over. Yes, sorry.
So, two things. One is referring to one of the first questions regarding the improvement or the expectation of timeframes, because there are a lot of outside factors outside of the child. And working with Ellen in a lot of cases in common, there are situations in school districts that don't have experience with CVI, which means that the vision services are predominantly the time in which the child has to practice if there isn't extensive training in advance of that student entering the environment. The other is if there's an environment that, and being in programs where Ellen has been previously, we're better suited because the environment was adapted specifically to the population of children that are there, which can drastically impact any of their improvements, their gains on their IEP, co-treatment with their physical therapist, their occupational therapist.
Absolutely.
Addition of music therapy and those types of things that also greatly impact the child's success. And then in response to Meg's question, you have to assume first that the TBI accepts a diagnosis or is able to identify a diagnosis of CVI. And then, because I've been in situations where they don't agree with a diagnosis or they don't believe in a diagnosis, and then that leads to having to do an independent evaluation to really see what's
Right.
going on and how to modify.
There's some TBIs that don't think this is their job,
Yeah.
and shame on you. Shame on you. But, you know, I don't know what else to say. You're right, I would go out and get it outside about, and also, there are people that will come to a training like this that is minimal amounts of information about how to do the CVI range, and go back and think they're doing it, and then I'll get a report saying, this child is operating in phase 4. And I think, wow, that's great. You know, there is no phase 4, but that's great. So you know, if you don't know, that's okay. If you don't find out, that's not okay. Because you're going to have these kids on your caseload. It's not okay not to know. It's not okay not to know. I feel very strongly about that. So we're just going to, I just want to talk to you a little bit about a little boy that, just to give you an example. I met this little boy at 9 months old. He was very premature, weighed 4 pounds, 3 ounces, paraventricular leukomalacia. He had motor impairments and cortical visual impairment. He went to an ophthalmologist that diagnosed strabismus and nothing else at that point. And we started working together. We put some of the strategies in place to improve his vision. This is what he was like at 9 months. He only looked at red and purple, only if they were a single color, if the item were a single color. He only looked if something moved. If something was stable, he didn't pay any attention to it. He had up to 15 seconds to locate something. Just count to 15 to yourself. That's a long time. He didn't look at anything unless it was 8 to 12 inches away. He only looked at things he had seen in his environment for a very, very long time. He constantly looked to the left and not to the right at all. I could not get any responses at all to the right. He looked out the windows or up above to the overhead light pretty consistently. He was overwhelmed. If they went into a busy place, he started to cry. If they took him into a noisy place, he started to cry. And he had no blink to thread, no blink to touch. At 3 years, so he was scoring at 2 at 9 months old. At 3 years old, he scored an 8. He looked at all colors, all multicolored objects, but he still needed colored highlighting around the hole in order to put something into it. He could not figure out where to put it unless that color highlighting was used. This is why it's very important to know what a child's favorite color is, because you want to use that color to highlight those more difficult visual tasks. He went through a point where he was totally distracted by any peripheral movements in the environment because he started to get more distance vision. His latency had dropped down, but you saw latency come back in noisy environments challenging. His lateral fields equaled out. He had the same responses on the right side that he had not had before, but his lower field was still affected. He could not process faces. He needed less than 4 visual targets. If you started putting 6 things on a board, for instance, he couldn't process all of those things. And he had more trouble processing 2-dimensional than he did 3-dimensional. So I could show him an object and he could tell me what it was, but if I showed him a picture of that object, it took him a long time to figure out what it was. He noticed things that were 10 to 15 feet away, but it took him a little bit longer to process what it was. So he was a looker, but especially at distance, it took him much longer. He looked at new and novel things when they came in the environment. He looked while reaching and he looked while playing. And his blink to touch was immediate and his blink to threat was immediate. His mother told us a funny story that she came down one morning, he's 3, and he's talking, they were Turkish, and he's speaking in Turkish, so she goes into the living room and he had taken the iPad and Skyped with his grandfather in Turkey. So I guess it was resolving. So that's just an example again of just the improvement that you can see. Now obviously this little boy has some wonderful cognitive skills, but you have to expect improvements from everybody. I want to talk a little bit about fluctuating vision. You'll see this a lot when people talk about CVI, and fluctuating vision is a term, again, I think blames the child. And kids definitely can have differences in their visual skills at different times due to alert state, seizure activity, fatigue, all of those things. But as a teacher of the visually impaired, I always want the person to say to themselves first, what's going on in the environment? What's happening around that child that could be impacting this? So don't jump to fluctuating vision. Think about the environment first. If everything is in place for them to see the best that they can see, then maybe fatigue is the issue. But I just really feel like that whole, that he sees sometimes he doesn't see others is just not good enough. We need to really be assessing the environment. Our brains can filter out everything. Our brains can filter out noise, can filter out visual information, and these kids cannot. You ever see that kid that can hear like somebody talking like 2 doors down? It's amazing. They can't shut that out. They just can't shut that out. So this is a little girl who is, she's in preschool. So this little girl is sitting at the snack table. She is surrounded by other kids, and she has her cup in front of her. So, and she's a child in phase 2, by the way. So just watch her as she's sitting at her table. She doesn't notice this cup is a favorite cup. She loves this cup. She sees this cup. She's trying to get this cup so desperately. She just doesn't know where it is. She's looking away, really struggling. Now I'm going to shut that off for a minute. She's touching it, but her tactile skills are poor, so she doesn't recognize it by her tactile sense. And I think that's a very important concept too. Here is this same little girl off at the side of the room in a totally quiet environment, and this is her skill with the cup. She watches the cup up above her, she watches it left, she watches it right, she follows it completely in a circle. I put it down on a mat, she reaches and grabs it immediately. That is not fluctuating vision. That is an environment that is not set up for her, was not set up for her to learn. So what we did was we took Abigail to a separate part of the room, built her skills with this particular issue, and then gradually moved her back in. We moved her to the snack table with 1 other kid, then 2 other kids. Now she can sit in the middle of the room and self-feed. So again, it's thinking about where kids are, creating environments, pulling those away when appropriate. So I think that's a very important concept to remember about kids with CVI. So expecting improvement, very, very important. We have to base our goals and objectives, and Terry's going to talk later about IEPs. Learning support should be around the characteristic and matched to the functional vision. and supporting the child's needs. Then pulled away when the child has made improvements. What happens so often is these strategies get put in place and they're left in place. That's not going to improve a kid's visual skills. It isn't a therapy. You want an approach all day long. That's why, as we said, we really want to be, I always have the same, if not more, consult time with a team than I do direct service. Because I want to know in that direct service where the child is functioning, but I really want to have everybody understand the concept of CVI. So in the additional information in the IEP, I'm going to put that I need an in-service every September around what cortical visual impairment is, and a second in-service that says, how does that affect this particular child? Yes?
With the example you were just giving with Abigail, I just wanted to make sure I understood. Did you gradually increase the complexity of her environment?
No, I'm sorry, I was reducing it. I took her to a quieter part of the room, I took her up against a wall that had nothing behind her,
Right.
so I reduced the visual complexity and the auditory complexity.
So
But
would she
you
be able?
increased it.
And so, I'm
But
sorry.
eventually you started increasing.
And then I increased it. Once she got the skills, once she was able to locate her cup and feed, and then we could move her back to the snack table. So the goal was always to move her back into the more typical environment, but very slowly, very carefully to maintain those skills and build those skills.
So if Abigail is introduced to a different environment, will you need to change familiar things? When she comes in a completely new environment? Is that a strategy for helping her?
Yes, absolutely, yes, yes. Yes, the support would have, in a noisy environment, the supports would have to be in place. Or just the recognition that this is not a vision time. Like we go into a large music class, she's in school, and we go into a large music class, and I can't make that visually non-complex, so it's an auditory event for her.
But
So, go
a
ahead.
quick question in regards to what Tony was asking was, for the new environments, because say, she's moved up in the Roman scale,
Mhm.
but if she transitions to a new environment, sometimes she may go backwards and then go forward again with the
Right.
input, but sometimes they can continue forward with the new environments without making it less complex.
Yes, I think what I see happening is that she builds skills in her familiar environment. You take her to a new environment, let's say a new classroom, and skills just aren't that good for a while, but they come back up. They don't, because she's
Right.
built those pathways.
Right, okay.
Yes, absolutely. So just moving on to Dutton, he's doing the same thing. He's talking about strategies, but his strategy he's talking about is for the current functioning. There's not a lot of conversation about strategies to address the improvements. Here are a couple of his books, and these are both noted, are noted in the bibliography. Visual impairment in children due to brain damage, cerebral vision impairment in children, and vision in the brain is the latest one. He created the Dutton Survey. The Dutton Survey has 52 questions. Let me just go back. 52 questions on it. There's no mention in the survey questions. There's no mention of color, movement, latency, light gazing, or visual reflexes as a characteristic. That's in contrast to Christine Roman's. Most of his questions are about visual fields and complexity. So I think it's important. One of the exercises that I do in my graduate CVI class is to have people take the Dutton survey, cut it up, and put it into the 10 characteristics, because it's important to compare to see what people are saying. People are saying all the same things. I think Dr. Dutton is spending a lot of time talking about complexity, which is a very huge issue with CVI. And I think we already addressed some of that. So CVI Across the Ages. This came up, and I think the question is, once a kid is older, should we worry about CVI anymore? If they were, and I'm not talking about acquired, I'm talking about kids that have just become diagnosed with CVI because no one knew what the heck it was all about. And I think there's two issues there. One is plasticity of the brain, and one is critical periods. Those are sort of two ideas that you have to think about when you think about the brain. And what's the potential for resolution with increasing age? Certainly, your brain is much more plastic when you're younger. I have to learn a language before the age of 10 to not have an accent. There's definitely proof that there are critical periods about older kids, they still deserve service. They still deserve to have an evaluation. Their improvements, I don't have a crystal ball. I can't tell you how they're going to improve. To me, it's all about access. So let's just cut out here for a minute, and I will read something that I got from a teacher that was in one of my classes, and then I'm going to turn it over to Tracy. So this teacher of the visually impaired did an assessment. She looked at color, she looked at field, she looked at distance, she looked at visual motor, she looked at light, she looked at all the 10 characteristics. She then bought this little tiny sticker joystick that she put red color highlighting on the tip of the joystick and placed it on the iPad, on the icon that would advance it to the next photo. So this is what happened. Get rid of these so it's not distracting. So this child, given that access, could reach out and access her iPad by touching the correct place to get what she wanted. Is this child going to improve? I don't know. Does this child have visual access now? Yes. And that came because that child had an assessment around the 10 characteristics and strategies were put in place for that child. So I think for the older children, I would say the same. We've got to make sure that they have access. I'm going to stop and let Tracy come on up.
Well, thank you, everybody. Right before lunch, so this is a little exercise in delayed gratification. I'm going to give you just a few takeaways. I think that connects quite a bit to what was discussed this morning. So, as you leave and then grab your lunch and then go outside, these are some really important messages that we want to make sure that you come away with. So again, as mentioned by Dr. Cran and Derek Wright and Ellen Mazel, remember that CVI is the leading cause of visual impairment in children in the United States. And when we look at where we are internationally, certainly that is beginning to be the same issue. When we look at things like looking at an individual's history and key ideologies, and I think this is so important for those of you here that are from MCB and the kind of work that you do. I just wanted to indicate that I'm a TVI. I've been on the road with many of you over a span of probably about 25 to 30 years. I really think that it's so critically important that we look at the identification of CVI and as most commonly associated with CVI, those particular conditions. I do think that a lot of the work that Dr. Roman has put forth, as well as Dr. Dutton's work, really leads to, we are sort of on the cusp of really looking at evidence-based practices around CVI. We're not there, but I think we really have some promising practices as we move forward. I really believe that teachers and caseworkers need to review the individual's history and medical records and conduct a thorough family interview in order to gather accurate information. There are some CVI red flags, and I know the guest speakers this afternoon and tomorrow will be mentioning these. I'm not going to go into these in depth, but when you see things related to asphyxia, intraventricular hemorrhage, PVL, accidents, stroke, infection, CMV, meningitis, structural abnormalities, metabolic conditions. Many of you, I know, are on the front lines of individuals when they first become diagnosed with CVI, or young children in particular. And I think it's really important that you pose the question, has this child or individual been screened for CVI? Because I can't tell you the number of times in my work, I see kids that are 15, 16, 17 years old, and no one's asked that question. They look at them under this diffuse umbrella of multiple disabilities, diffuse brain damage, and really never really look at whether CVI is an issue and whether intervention and supportive practices could help this individual. I'm bringing up the issue of traumatic brain injury, and I don't want to get into a whole debate of correlation implies causation. However, when those of you are looking at records and you see things, for example, the child, there was an incident of falls. It may be a teenager related to traffic accidents. It may child that hit their head, so that may be reported. Those are cases where you really, again, need to present it to the team or service provider or a family member and ask, again, has this child been screened for CVI? So where we've been going and where we've been and where are we going, I spent many times on the road with Sue Christensen here as she was a caseworker at MCV, and I can tell you, I look back at my caseload and the number of kids that I worked with, and at that time, I had no clue that cortical visual impairment would have been an issue. And knowing what I know now, I know that I have sort of a bag of tricks or knowledge base where I would have done things very, very, very differently. So I want to give you again a little bit of sort of an overview of where we are related to some of the awareness and knowledge around CVI, and this relates to the Deafblind census data starting in 2004 to 2013. When we look at 2004, typically each year there are around 10,000 cases or 10,000 children identified birth to 21 as having combined vision and hearing loss in the U.S. So in 2004 we were around 1,481 children identified, so say roughly 1,500. So when you look at where we are today, and there were some glitches here in terms of the data collection, we're almost double that. And I will submit it's because people have taken the time to learn more about Dr. Roman's work and Dr. Dutton's work, and it really has made a difference for kids and for families. So we're also currently in the process of developing a medical brochure for medical providers as well as vision care providers. We still see, especially in more rural areas, kids, again, who are sort of written off as multiple disabilities, severe brain damage, and no one asking that question, has CVI been screened for? Are there particular intervention strategies that we can do to support that individual? So I threw a bunch of takeaways in number 4. But again, I think it's important for all of us to recognize that CVI is the first step towards rehabilitation and prevention. If we don't know where these kids are, who they are, we can't possibly get the services to them. And as mentioned by Barry and Derek this morning, children and adults often require modifications in the examination. I would also submit that's especially true for children that have combined vision and hearing loss. You really have to look at those two senses and how they're being presented within the assessment process in order to get accurate levels of responding. And again, mentioning we still rely so much on acuity measures, and I think we've learned a lot this morning that's really not true. So the prognosis for improvement of visual impairment, I would say that the work that's been done in Pittsburgh, the pediatric view that Dr. Roman has been pretty instrumental in, they have, they're sort of on the cusp of submitting some of that data. I haven't seen it yet, but I have heard the results are really positive around the intervention strategies. So again, I think what's important for you folks to leave with today is the message of please remember the importance of your role in linking services to children and adults who either have CVI or who are at risk. Because I know many of you, again, in your work, you're directly connected to many of these families, and you're attending various educational teams. Don't be reticent to ask the question, has this child or individual been screened for CVI?
I just saw a new client this week who he's a 62-year-old adult male, had a stroke in April, lost vision. He's being treated at Lady Clinic. Can't I assume that he's been screened for that?
I would never assume that. I would, again, in part of your role, ask the question. I think it's really, really important. And as we know, I mean, especially with all the medical, all the medical things that are going on, often it's the last question because there are so many other things, other priorities at the forefront.
And I think also we're in that terminology issue here. I mean, I listened to what you were just saying about the 60-something-year-old with stroke. I would not, if you said, Derek, have they been screened for CVI? I'm going to say, what? CVI is a pediatric thing. That's, I think of that as in a different category. So I would just challenge you, be aware that we're using different terminologies here.
I might just call it functional deficits or something else, right?
It's an issue for the panel tomorrow probably, but again, for me, I think it's so typical for the individuals I work with. The focus is
CVI screening, and you bring up that you wonder if the child's been screened, but the team or the parents are kind of resistant. The child's seen a lot of other eye doctors, they have a lot of other medical issues, but you've done your screen. Would you start recommending those strategies like in the plan, or does it really have to be?
It depends, what's your role?
A TVI.
As a TVI, I would definitely keep bringing it up. And if I had that knowledge base and I felt comfortable in the use of the CVI range, I would certainly do that within my realm as a TVI. If there's disagreement, I think you have to keep bringing it back to the team now, the resolution.
Can you use, I mean, if you find like some of the, but then you could use some of those strategies, let's say, when you look, but you just don't call it, saying like the child has like a color preference or things like that, these may be helpful.
Well, again, it's hard to kind of go in there and do
Yeah.
interventions without
Yeah.
being sort of
Right.
as part of the whole
Right.
team. So if you're working in isolation, that might be a little tricky. But I would kind of keep beating that drum around educating the team around CVI. Ed,
Well, one of the things I'm hearing is talking about that 63-year-old is the ODs and ophthalmologists are diagnosing this cortical blindness issue. They're looking at the ocular health, as you said, and that it's not going to be addressed because they don't, one, know it needs to be addressed, and two, it's the ocular eye we're looking at, not the function. And that's where you have to break it down in regards to addressing what's the function.
well, I think what's also a problem is to look at it empirically. You know, we're at the cusp of developing these interventions and having those interventions be validated. And I think many in the medical profession are going to look back and say, well, show me the evidence that this intervention actually improves visual function. We have some studies. We need a lot more. We have a couple of reliability studies that I think need to be strengthened and repeated across multiple different populations and age ranges. So I think there's a lot of factors to why that doesn't occur as well.
One final question.
One thing to remember, and especially for those that are working in classrooms, I'm not a TVI and I advocate for children on my case through mission, but there have been special education teachers who have approached me and said, you know what, some of those CVI strategies that were brought on by the TVI work for other kids in my classroom. So they are similar to the typical special education
Right.
course. There are some that are very different, but it's not going to hurt anyone regardless of a diagnosis.
I think that's a good point. I also think, again, as TVIs and folks in the vision world, we need to